Cannot
Thank
wait to hear
you.
it.
Thank you so much. Let me share my screen with everyone because we got a lot to go over this evening, let me tell you. So I appreciate you all joining me today. What a wonderful group. This is awesome. I'm seeing about a little over 300 people on tonight. So I appreciate you hanging out with me tonight. I didn't realize that the St. Louis chapter was so large. How incredible. This is great. Now, not everything we're going to talk about tonight is going to be fun, but it will be the most up-to-date information that we have available for us. But you know that in this ever-changing industry of ours, the only thing that we can really count on is change, right? So, everything, if you're looking at this information in the future, then you may want to double check to make sure that nothing has indeed changed. For those of you that we've never met before, my name is Christine Hall, and I've had the pleasure of working in this industry for a little over 30 years. Can't believe it. It has gone by so fast. But the truth is that I love everything that has to do with compliance, coding, billing, auditing, risk adjustment. Listen, I love evaluation and management. I know, right? I am a certified instructor with AAPC. I'm currently teaching their virtual instructor-led training courses for CPC, CPB, CRC, just to name a few. I am your current chairwoman of the AAPC Billing Advisory Committee. The committee works on various projects and we assist with articles for the Healthcare Business Monthly. We also put on a lot of ask and learns and some webinars along the way there. I have a podcast every other Tuesday at noon. As a matter of fact, we're going to be on tomorrow. And this season on the podcast, we're talking about CPT. So hopefully you can join us. And if you can't, that's okay because we're on just about all the streaming platforms. I feel like I need to tell you that I am a survivor of 5 children. Yes, they're all grown and it did happen. I'm here to tell the story. I am a proud grandma of 2 absolutely amazing little people. And you also had the pleasure of meeting my office manager, Mr. Toby Hall, and he's never far to make sure that I'm providing you with good quality information. So let's start with the updates this year. Not as many updates as we had last year, but it does bring our total CPT codes to 11,163 codes. That's a lot of CPT codes. Now, there were 230 additions, 49 deletions. And listen, oftentimes those deletions are because we've had to change a code in a way that required a new code. So there's a balance there. 70 revisions, and a lot of those revisions are editorial, and you'll see that where they've changed terminology within that particular code, but not enough to actually require a new code to be presented there. I am going to be going over a few of the new guidances that have been added in the 2024 book. So for those of you that you get your book and you kind of focus on just what your specialty is, or maybe you looked at E&M, or maybe you do a little in the surgery section and in the medicine section, but you don't really have time to read all those new updates. Well, I'm going to share those with you in kind of the Cliff Note version of it. If you want to follow along, you'll notice at the bottom left-hand corner where we talk about guidances, I will give you the page number in your CPT book. Maybe not all of you carry your CPT book between work and home like I do. But if you happen to work from home and you have your book handy, you might want to go grab that just to follow along. Or when you get a copy of these handouts tomorrow or later this week, whenever we've got time to get them to you, then you can always check that bottom left corner to have that page reference there. So first thing I'm going to talk about are the changes to the instructions of CPT. Believe it or not, we've got some instructions in the beginning of CPT, very similar to the instructions that we see in our guidelines for ICD-10. But a lot of times we kind of overlook those things, and that's where we see a lot of great information. This year, CPT thought that it was important that we talk a little bit about selecting the most appropriate code and reminding us that we've got category 1 codes, and those codes are codes that have been valued. They actually have RVUs attached to them. We've got our category 3 codes, and those are temporary codes that we're given for that new technology. They don't actually have any value attached to them yet, but with enough reporting and documentation, those have the potential of moving into a category 1 CPT code. And then, of course, we've got unlisted codes. And I'm thinking that maybe CPT felt like our unlisted codes weren't getting enough love because they talked about them quite a bit in the introduction this year. So we're going to take a look at that. Now, remember, anything that is submitted with a category 3 or with an unlisted code, we're going to need to submit documentation. That's how we change that code from a temporary code or an unlisted code to a permanent code. Now, the other thing that CPT wanted us to remember that a lot of our codes are combination codes, or maybe they're representing more than one service. And when we have a code that represents more than one service or a bundled code, then that would be the most appropriate code if it matches the procedure. So the example that's given in CPT is that we have a code for tonsillectomy. We also have a code for an adenoidectomy, but we have a third option, which is a combined code for a tonsillectomy and an adenoidectomy. And if that was happening at the same time we're doing tonsillectomy and adenoidectomy, we would report our 42820 as opposed to reporting a separate tonsillectomy and a separate adenoidectomy. I know it sounds like common sense, but common sense is not so common these days. And somebody made it a point to publish that in CPT. Now, another thing to remember is that sometimes we have procedures that include certain components of them. We shouldn't be billing those additional components separately. So, for example, here, they're talking about an incision and repair. So if we make the incision, many of our integumentary codes include the repair or simple repair, right? Also, if we're having a surgical procedure and we need to get to an organ inside, we have to do an incision, and that's included or bundled into that category 1 code. So we have to really make sure that we are looking at our codes completely to understand whether we should be reporting separate components or not. This is one of my favorite. Telehealth has been probably something that is near and dear to my heart since the Jetsons. And I'm talking about Saturday morning cartoons. You remember those? We'd watch the Jetsons on Saturday morning. I thought those were the coolest cartoons. And I really thought that in my lifetime, I hope that I start to see some of those things. I was always very curious about that. So I started following telehealth. I joined the Southeastern Telehealth Resource Group back in 2017 before COVID. And I was so blessed that I was able to help so many people out during COVID transition over to a telehealth-based platform when we were on lockdown and we couldn't get out and we couldn't treat our patients, right? So we needed that alternative, and I was really happy that I could help out. But now that the public health emergency is over, the big question that I'm getting these days is, Christine, do they still cover telehealth? And yes, most payers still cover some modalities of telehealth. Now, telehealth includes those audio video communications. So just like we're doing right now, I can see you, you can see me. Well, I can't see Ashley. I can see Ashley's ceiling, but I know she's there, right? And so this is an interactive audio video communication we're having, and we're having it in real time, right? So that's one modality of telehealth. Another modality of telehealth is audio only. So for example, if you couldn't see me anymore, where did I go, right? You can only hear me. You have no idea what I'm doing in the background right now. You can't see this funny face I'm doing. No, you can't, because it's audio only. So while we're doing telehealth, right, there are different modalities there. And the question isn't so much, do they pay for telehealth? The question is it appropriate for us to be doing telehealth? And so in our CPT book, AMA gave us some great guidance to encourage us to refer to when we're considering using telehealth for a visit, right? Does it facilitate a diagnosis and treatment or a plan that's going to reduce complications? Does it decrease diagnostic and therapeutic interventions? Does it decrease hospitalizations? Will this telehealth visit decrease an in-person visit to the emergency department? And you could read these in the beginning of your CPT book there, and it's a great guidance. And if for any of these reasons you answer no, that's not the reason I want to do telehealth, then you might want to reconsider that, right? So another thing, I was telling you a little bit about those unlisted procedures. And again, CPT is really trying to push these unlisted procedures when we have a procedure that doesn't fit a category 1, doesn't fit a category 3. Those unlisted procedures is how we get that wheel turning to have new category 3 codes or have new category 1 codes. Or maybe this is just so unique that we haven't really found something that fits that particular procedure. So they've given us also some wonderful examples. The example that they've given us is perhaps a patient's coming in to have a radiofrequency ablation done of the greater saphenous vein, but they also need to do some stab phlebectomies. So they make 10 little incisions there. Well, there's not really a code that would describe that stab phlebectomy with less than 10 incisions there, right? So because there's no category 1, no category 2, we're going to report that with an unlisted code. Still need to submit documentation so that the payer understands what we're doing, but that's how we report that individual service. It's a little bit different than any other code we might have. So it's important to use those. We can still use that modifier 59 to talk to the payer, to communicate with the payer that this is a separate encounter, a separate procedure, a separate site, whatever that happens to be that satisfies that modifier 59 there. They also said that sometimes you might have just an absolute firecracker provider who is performing 2 particular services on the same day, but they're both going to fall into that unlisted. And it's okay, right? So when that happens, that we're going to report those 2 separate unlisted codes, and we're going to report that modifier 59 to, again, communicate with the payer that these were 2 separate unlisted codes. Send that documentation in as well so that the payer can see exactly what those 2 separate procedures were, and they won't think that we're just trying to report the same procedure twice. Also, we have to remember a few things that when we're using those unlisted codes, we're not using those enlisted codes in lieu of maybe a modifier 52. Here. For, oh, did I have a question? Okay. I get so easily distracted. I'm a lady of a particular age, and if somebody's got something going on in the background, I'm probably going to want to know what's going on. Anyway, but just to remind us that there's a time and a place for it, and they've given us some really amazing guidances for reporting unlisted codes with other procedures. So take a look at those within the CPT book. Now, one thing that needed some updating, and they did a great job of this with CPT, was for some of those time-based selections. Now, time is very different when we're talking about evaluation and management. So we're not talking about evaluation and management just yet. When we get to evaluation and management, those guidelines will talk about time and how time is updated or how time is supported. But in these guidelines for CPT, they're simply talking about time and what is the midpoint of time. Some of our codes will allow us to report a midpoint. So when at least half of the time is provided, then we can report that code. So when we're talking about maybe things like hydration or other services that are time-based services that are not evaluation and management, we can report those services once we've met the midpoint. And midpoint guidance was always there, but they expanded it and they gave us an example in CPT this year. Another thing that was clarified in CPT this year is what happens when a service starts on one date of service, but the service doesn't conclude until the following date of service. So in this example, maybe IV hydration is started at 11 p.m. and continues through 2 a.m. How do we report that? What date of service do we report for that total time? Well, we're going to report that continuous service on the date that the service was initiated and it started. So if the intravenous infusion started tonight at 11 o'clock, we would use today's date of service, even though that infusion is going to continue through the midnight hour into the next morning, but it's continuous, right? And they gave us that guidance. Now, I'll be honest, I don't know what changed here. This was identified in CPT as something that had changed, but when I compared my 23 book to my 24 book, I didn't see any change. So what they've identified is just to remind us that we've got some certain appendixes out there that are related to those symbols that we see within CPT. So when we see the plus sign, there's actually an appendix D as in David that has all of the add-on codes listed. The no sign is appendix E, and that has all of the codes that are exempt from modifier 51. The lightning bolt sign, that's appendix K, and the lightning bolt sign means that the vaccinations in question are still pending FDA approval, but we believe that we are going to get that approval probably within this calendar year. And so we've gone ahead and given it a CPT code and we've moved forward with it. Again, one thing I want to remind you is CPT codes are not a guarantee of payment. CPT codes are strictly the language that we translate the medical record into so that we can communicate with our payers, with our statistical entities, to communicate with those codes there of what was performed. So the number sign or the hashtag sign or the pound sign, depending on how old you are, right? Those are all listed in Appendix N. And all it's telling you is that CPT knows that those codes with that symbol are out of sequence, but they made sense to be grouped with like procedures rather than being grouped numerically, right? The star symbol, well, those are for the CPT codes that can be performed via telehealth. Again, not a guarantee of payment of telehealth services, but simply those particular CPT codes that have been indicated as can be reported via telehealth. Not talking about the CMS telehealth list. I still recommend going out to your payers and seeing what codes your payers will pay for out there. But that star symbol tells us what CPT codes have been designated as an audio-video two-way communication service. The speaker sign is just advising us that those are codes that can be performed audio only. Again, not a guarantee of payment by any payer whatsoever, simply saying that these particular CPT codes can be reported audio, that we've seen that they can be reported audio. Again, not a guarantee of payment. All right, the moment we've all been waiting for. Drum roll, please. Let's take a look at who are our major players here with our changes this year. So we've had one additional evaluation and management code added and 10 revisions. We're going to get to those at the end. We're going to save that time so that we don't have to rush through evaluation and management. Nothing for anesthesia or the integumentary system. And for someone who codes for derm, thank God. Musculoskeletal, a few additions and a few revisions. Respiratory, a couple of new codes for respiratory. Cardiovascular, 8 new codes in the cardiovascular system, but nothing for GI. We're clear there. 1 for GYN. We have 6 new codes for the nervous system, 4 revisions. We have 1 code for the eyes and adnexa. Nothing for the ears. So those audiologists, you're good. We have 5 new codes in radiology. We have a lot in Path and Lab, and we always do. And we seem that's one category that always seems to be expanding. One, we have proprietary lab analysis. We're not going to go over all of those proprietary lab analysis. I do have a short little snip of what that looks like for you. Because if you are working for a proprietary lab, you already know these codes. You knew them way before we did. Also, another booming industry is genetic testing. And so because we are able to isolate more genes that have any type of abnormalities, then we're going to, of course, have more codes to report those specific genetic abnormalities. Medicine section, a lot of changes in the medicine section, 43 additional codes, 12 revisions. We'll talk about that, mostly because we have given ourselves separate medicine codes for programming of implanted devices. You're going to see that a lot tonight. Category 3, 83 new Category 3 codes, 13 revised and 32 deleted. Most of those deletions were promoted to Category 1 codes, and I got a few of my favorites I'll share with you. So without further ado, let's go. Now, you will notice that anything and everything that is new for CPT is going to be in green ink, just like you see it in your CPT book. Anything that is revised will be in blue, just like our blue triangle indicates in our CPT book. And those things that have been deleted are going to be in red for us today. So just to give you a little legend to follow. Now, the first thing isn't necessarily a new code. The first thing that came up was some new guidance. Now, this guidance is to help advise that when you've got 2 primary surgeons that are performing different parts of a spinal deformity arthrodesis, each provider uses the same code, and they're going to report that part of their service with a modifier 62. So that was what they were giving us that clean information. That information also is for your deformity arthrodesis codes, kyphodectomy codes, your thoracic vertebral body tethering, and those are some new codes that we're going to talk about tonight. Lumbar and thoracolumbar vertebral body tethering, those are new Category 3 codes. And for thoracic vertebral body tethering there. Again, that could be done by 2 surgeons. And so we're going to utilize that modifier 62 in those cases. So a little more about these new anterior thoracic vertebral body tethering. Now, a lot of times when we get new codes, CPT will give us some instructions on how to properly report those codes. And you're going to see that in the very beginning of that section. And so what they're advising us here is that there's a new approach to the anterior thoracic vertebral tethering. It's kind of neat. Instead of fusing the spine, they're using a cord to squeeze those vertebrae on one side to kind of slow the growth or the curvature of that scoliosis. Pretty interesting. By using this tethering or this cord, it allows the spine to keep growing as opposed to a fusion there. So really awesome. Now, of course, we could have 2 surgeons that are providing this this vertebral body tethering. So when that happens, we want to report the code with a modifier 62 for each one of the providers there. Now, here are those new codes. And these codes are going to include your thoracoscopy. Thoracoscopy. Oh, it's late in the evening, guys. So if there is some pronunciation errors, please don't shoot the messenger. I'm doing the best I can here. But we've got these new codes to describe this vertebral body tethering, right? Not so much a fusion anymore. And that's kind of cool. So there are our codes. You've got your anterior thoracic vertebral body tethering, including your thoracoscopy when performed up to 7 vertebral segments. You've got an indented code to that root code, and that indented code is for the anterior lumbar or thoracic vertebral body tethering up to 7. Actually, I think that there's something missing there. I'll have to ask Lexi, but we've got some new codes. It should be for the actual vertebral body tethering, and then we have for revision, and that's probably our removal code there. And notice that there are some category 3 codes also in those parenthetical notes to help us out there. I love the way that CPT has given us more and more parenthetical notes. There is a new code for a minimally invasive procedure where they're using a small device to fix that sacroiliac joint in the lower back. So they put this device through the ilium and across the sacroiliac joint and into the sacrum, and they make that sacroiliac joint stable. So that's how we usually have been doing it. We report that with our 27279, and that's a fixation that's happening there. So it's transfixing with a device. But we have a new code where they're actually using more like a cement product. It's called a LinQ or a silo or a corner lock. And they're doing that to secure that SI joint as opposed to a permanent fixation device there. Now, there is some guidance that was added additionally to remind us that there's a difference between the two. So if we're doing that transfixation, we're going to report the 27279. But if we're using non-transfixed, we're using that cement compound, then we're going to report that new code 27279. And look at all the parenthetical notes that have been added. Even the inclusion of if it's done bilateral on both sides of the SI joint, then we're going to use a modifier 50. Let me tell you, from a coding perspective, when they give me those modifiers, it's like a Christmas present. We had some revisions to the correction to our bunionectomies there. So all they did was they added the word with. They removed the parentheses around bunionectomy. And now since they changed the base code, everything that is indented is also represented as changed as well, right? So the whole thing, because of that base that's been changed, it really does affect all the other codes as well. Now, one cool thing is that for the 28297, they've also added a parenthetical note there. So they're telling us that if another scenario exists, we're to report a different code. So those parenthetical notes can be so very handy. Listen, I love my encoder and I love my ebooks, but there's something about my paper books that allows me to go in and look. And I'm kind of programmed at this point after 30 years to know where I'm looking. I go in looking for those parenthetical notes, those parenthetical guidance that may not be so easy to read in my encoder, right? Nothing changed to the 28740 arthrodesis mid-tarsal or tarso-metatarsal single joint, but they did add a parenthetical note. So that parenthetical note there is advising us which code should be used. I thought this was a pretty interesting new code that was provided to us, and it is out of sequence, but it's pretty interesting. What they do is they take a special tool, like a thin wand, and it's used to treat chronic rhinitis. So they'll go in and use either radiofrequency ablation or a cryoablation, and they'll go in and destroy the nerve that makes too much mucus in the nose. And although I've not had this done, but I've heard from many offices that it can be done in the office. They just use some local lidocaine to numb the inside of the nose, and it doesn't take that much time to recover. And from what I've heard, the pain is minimal when it comes to this procedure, very successful. So for a very, very long time, we have had pacemakers. As a matter of fact, pacemakers started around the late 1950s. We started seeing these. And pacemakers, for the most part, they require the surgeon to make a pocket under the skin and put in some leads into the different chambers of the heart. But now we have leadless pacemakers where everything is included in a little capsule, including that pulse generator, the battery, right? And so doctors can put them into the heart and they work just like the old pacemakers do, except there's no wires and there's no surgery that's needed for these types of leadless pacemakers there. So, of course, whenever we have some new codes or new guidance that's given us direction for codes, then we also get an updated table. So I'm sure you can't read this. It's really, really tiny, but make sure you're looking at page 242 or 243 in your CPT book. And there's an update to our pacemakers and defibrillator code selection or code table there. Now, another new set of codes also comes with some guidance, and it's for the insertion of a phrenic nerve stimulation system. And what that does is it is very much like a pacemaker, but it's attached to the phrenic nerve. And the phrenic nerve is responsible for respiration, right? It's responsible to make sure that we've got good respiration happening. So they insert this, and then later on, about 30 days later, they go in and program it, and they're able to almost like a pacemaker for your breathing nerve to remind you to take deeper breaths or longer breaths or more frequent breaths. And especially for those who suffer from sleep apnea at night, that phrenic nervous system is really becoming cutting edge, right? So here are those new codes. And you've got the insertion of the phrenic nerve stimulation system. You've got the removal codes. You have the repositioning of those codes, the removal and repositioning of those codes. Again, not the codes, of the device, I mean. Again, long day, right? So one of them here is very interesting. So if we look at this 33278 code, it's the global code. It is going to include the imaging, the interrogation, and the programming when it's performed. But we also, and it includes the pulse generator and the leads. We also have a separate code when it's removing just the leads and a separate code for just the pulse generator. So they're separating out parts of that global procedure when it's appropriate to report. All right, moving into the urinary system. So only one new code here, and this is actually a promoted code. So congratulations. So this is your cystourethropy with the mechanical urethral dilation and the urethral therapeutic drug delivery by a drug-coated balloon catheter for urethral stricture or stenosis in a male. It also is going to include fluoroscopy. So there's a parenthetical note there that's going to remind us that we're not going to report this code with fluoroscopy because it's already included or it's built into this particular code. Another code that was promoted from a category 3 to a category 1 code is our transcervical ablation of uterine fibroids. This is going to include that intraoperative ultrasound guidance and monitoring and the radio frequency. So amazing to be able to go in and destroy some of those uterine fibroids and not have to have an invasive type of surgery there. Now, a couple of other things that you'll notice on here, I did give you a new parenthetical guidance for our existing laparoscopic surgical ablation of uterine fibroids, including the intraoperative ultrasound guidance and frequency. They're just advising us that there is a new alternative code if it is transcervical. So if we're not doing it laparoscopically and we're doing it transcervical, then we should use the new code 58580. One more parenthetical guidance was added to an existing code, 58661. For bilateral procedures, we're going to add a modifier 50. So again, I think it's great that CPT is holding our hand, right? They're helping us out here.
Christine?
Yeah.
I forgot to ask you at the beginning, do you want questions during or at the end?
Probably at the end.
Okay.
That way, if I happen to answer it, that way we don't slow down. I'd rather take the time at the end than not get through everything.
Gotcha. Perfect. Thanks.
Thanks. So we have some new codes that were added for the nervous system. These are the insertion of the skull-mounted cranial neurostimulators. Includes the pulse generator and the receiver. It also includes the craniectomy or the craniotomy when it's performed with direct or inductive coupling with connection to deep and or cortical strip electrodes. We also have a code for the revision or the replacement of that skull-mounted cranial neurostimulator, and then the removal of the skull-mounted cranial neurostimulator. So these are kind of cool neurostimulators. Now we've got some new guidance for our spinal neurostimulators. So we just talked about the skull-mounted. Now we're talking about spinal neurostimulators there. And what you'll see is that they're telling us that the programming and the analysis of these neurostimulators are not in the surgery section. They have moved all of the programming and analysis into the medicine section, kind of where it should be, right? And they've given them their own separate codes in the medicine section. So programming and analysis of the neurostimulators, that's now located in the medicine section there. There was a revision. Now, if you remember just a few slides ago on our skull mounted, the description there talked about inductive, direct or inductive coupling. Well, they've removed that terminology from our spinal neurostimulators. And they've added new terminology requiring a pocket creation and connection between the electrode array and pulse generator or the receiver there. Now, there's some new parenthetical guidance that has been added there to advise us of these specific codes when they should not be reported. And there is also parenthetical guidance to remind us that we've got a category 3 code that's just a little bit different if it's percutaneous. So if we're implanting these spinal neurostimulators percutaneously. Now there's another revision for the removal or the revision of the spinal neurostimulator there. And the same thing applies. They've got some parenthetical notes there as well. Basically, the same guidance was added to those neurostimulators that are implanted on the peripheral nerves. Just again, trying to remind us that surgery section is for surgery, insertion, repositioning, replacement, removal, surgeries, and that analysis and programming of these neurostimulators really belong in the medicine section. They're not of a surgical nature there. So they're simply just reminding us of that. And they have also added some revisions, the same type of revisions to those peripheral nerve neurostimulators. They did add a couple of new codes here. So the insertion or the replacement of a percutaneous electroarray peripheral nerve, not spine. Spine has a category 3 code for the insertion replacement. But for the peripheral nerves themselves, we've got a new code for that. It's an add-on code for an additional electrode array and a new code for the revision or the removal of that neurostimulator of the peripheral nerve. This one is super interesting. So this is a suprachoroidal injection. This is a really interesting approach, and it's for the targeted delivery of drugs to the posterior segment of the eye, right? So the subarachnoid space is that space that's between the sclera and the choroid, and it provides by administering this medication, injecting this medication into that space, they're seeing higher concentration of the drugs, increased bioavailability of those drugs, and prolonged duration of action of those drugs. So, of course, I'm not going to have that done because no one is sticking a needle in my eye. But there's a really good argument for it. I'm not going to lie there. Oh, one more thing. There's a parenthetical note to remind us to report the medication separately. And I think that's kind of great because oftentimes we might forget that we've also got to report the codes for the medication that was administered this way. So nothing changed with our implanted osteo-integrated implants into the skull. So those cochlear devices or other devices that are meant to help with external those external speech processors, nothing changed. However, they added a parenthetical note here that says, for the analysis in the program in the verification of the auditory osteo-integration sound processor, you got a new code in the medicine section. We don't do that here anymore. Radiology. Radiology, you have, well, they deleted the pelvimetry with or without placental localization. So pelvimetry was just to see if the baby's head would be able to pass through the pelvic cavity. So the first time, only time I ever heard of this was probably, let's say 30 years ago. I had a friend of mine. She was 4'10". She was married to a man who was 6'4", and they decided to have a baby. And we did not know if this giant baby growing inside this 4'10" woman was going to be able to have a natural birth, or she was going to need some surgical intervention to have this big old baby. And I remember her telling me that they had performed pelvimetry to see if her pelvis was even big enough or possibly could spread wide enough to deliver this massive child. It was not, by the way. And she ended up with a C-section, but the baby was super cute. So CTA, excuse me, of the heart. Coronary arteries bypass graft with contrast materials. That did not change for us, friends, but they did add a parenthetical note that said, if you're doing non-invasive estimate of coronary fraction flow reserves, or FFR, we have a new code for you, right, with interpretation and report by a physician or other qualified healthcare professional. So please make sure that you're not confusing that CTA with the FFR. And that's great news for us. New code, new guidance, and they reported the guidance in 2 different locations, so we can't forget about it. Fluoroscopy did not change, okay? But they did add or expand that parenthetical note that was there to include some of those codes that were not previously listed but maybe should have, or those codes that were Category 3 codes and got promoted to Category 1 new codes, or they're new Category 3 codes that include fluoroscopy when performed. And so it's just another one of those little safeguards to help us as coders not accidentally overcode when we have a procedure that already includes this kind of guidance in its intention for the CPT code. Ultrasound guidance for vascular access requiring ultrasound evaluation of a potential access site didn't change, but the parenthetical guidance did change. Same reason as fluoroscopy. We do have some new codes for ultrasounds, intraoperative thoracic aorta, diagnostic, not therapeutic, intraoperative epicardial cardiac ultrasound of the congenital heart disease, diagnostic. Though that is a global code, and that global code includes the placement and the manipulation of the transducer, the image acquisition, and the interpretation and report. Alternatively, we have breakout codes or child codes or technical and professional component codes that are not the global code. And so we wouldn't use modifiers with 76987, 76988, or 76989, because the 88 is simply for the placement manipulation of the transducer and the imaging only, and the 89 is for the interpretation and report only. So again, if your providers are doing procedures in the hospital or in the ambulatory surgical centers, then we might be reporting the 89 most often rather than the 87, the global code. Ultrasonic guidance intraoperative didn't change, but there is a new parenthetical or an updated parenthetical note there for us to keep in mind. Urinalysis, Simply a new guidance. Nothing changed with urinalysis, but they did tell us that a urinalysis procedure, remember, urinalysis is just an analysis of the urine. And if we're trying to analyze something that doesn't fit into the codes that we already have, 81000, 01, 02, 03, 05, 07, 15, 20, 25, and 50, you could possibly use a code from the chemistry section for that urine analysis, right? Or an unlisted code if that specific thing that you're looking for in the urine is not represented by one of the existing urinalysis codes, chemistry code, we'll use that unlisted code. That's all that they were telling us there. Now, they made some revisions to some new codes that we had previously in the last couple of years. Like I said, genetic testing has exploded. I think it's fantastic that we are finally able to make diagnosis when there have been people out there that have been struggling with syndromes or multiple symptoms out there that never had a definitive diagnosis. And through genetic testing, we're able to find these things out. So a few changes here. In the parenthetical note, rather than the AF4 FMR2 family member 2, that has been replaced with the terminology of ALF transcription elongated factor 2 or FMR2. The other thing that was removed throughout the entire CPT book was the term mental retardation, and it was replaced with intellectual disabilities there. So you'll see that quite a few of our codes were changed for that reason only. They have removed that term and replaced that term to be a little bit more specific and inconsistent with what we're actually dealing with, that intellectual disabilities there. A few codes that we had for genetic testing, they removed the specific examples. The way that it was explained to me was that some providers felt that if the gene was not listed in the example, that they could not report this code. And so rather than having the individual genes, they've revised it to a genomic sequence analysis panel, which more represents the intent of what we're diagnosing or what we're looking for, actually not diagnosing, but looking for in that lab test. So solid organ neoplasm, I'm not even going to try to pronounce that tonight, neoplasm, or a combination of the two neoplasms there. So this is for the initial 5 to 50 genes, and then you've got it expanded a little further into 51 or greater genes. This is for the DNA and RNA analysis, or this is simply for the RNA analysis down here. They've got one that's just for RNA. So revised. New codes. So a new code for solid organ neoplasm, geometric sequencing, analysis panel, interrogation, another word that's just going to leave me tongue-tied tonight, for a sequence variants there. DNA testing, genetic testing. So again, we're making great strides with these tests. New code for another liver analysis panel for 3 biomarkers there specifically that we're looking for in liver disease. We have some new hormone panels, new antibody panels, new Hep D panel, and we have a new orthopox panel. So we have orthopox is looking for monkeypox, cowpox. I forgot the last pox. Where did it go? Monkeypox, cowpox, and some other pox. I'll tell you when I remember it. Not in the middle of the night. Here shortly, I'll remember it. Anyway, I told you about those proprietary lab analysis. Not so many this year, 61 new, 10 revised, 13 deletions. The revisions were of some specific codes, and they're listed right here for you. Those are the deleted codes there, just a few of them. And we also had the addition of duplicate PLA, proprietary lab analysis, test symbols and parenthetical notes that were added to the code 0345U. The term quantitative was added to the code 0389U. They changed the terminology from CAD, coronary artery disease, to CHD, coronary heart disease for 0401U. So again, not all payers are going to pay for proprietary lab analysis. You do need to verify with them to see which one of those analysis that they will pay and what labs they have contracts with. All right, moving right along. So for our new vaccines, a couple of things here. All CPT wanted us to know that if we want to know the new vaccines, the revised vaccines that are out there, those immunoglobulin products, that there's actually a website that the AMA has published for us to go and take a look at those specific types of immunoglobulins, serums, recombinant products. Also reminding us in guidance of that little lightning bolt symbol that there are some of these vaccines or products that are not FDA approved yet. So a couple of new RSV. We have our seasonal dose. So I've been noticing a lot on TV that they've been talking about going and getting your RSV vaccines. So these are the vaccines. There's a different dosage depending upon the age of the patient. But we've got different RSV vaccines now for this particular season. I'm sure that it'll change much like our flu shots change. A little bit of guidance when it comes to vaccines, simply stating that we've got a lot of vaccine administration codes for COVID. And a patient might be coming in for a COVID vaccine, but they might be coming in for another vaccine as well. And in that case, it is okay to report a COVID vaccine administration and another type of vaccine product administration with those specific codes there. And that's really all they're telling us, reminding us that there's a great table in Appendix Q for our COVID vaccinations. And the same thing kind of aligns here that they're talking about. Really, it's just guidance on administration of vaccinations and toxoids. The table for COVID injections and administration of those injections, I know that the AMA in their last errata, that there are some changes that are coming this way. This is the only thing that I will tell you. I don't have that new information as of yet. So that might be something that we keep our eyes on. And as soon as it comes out, I'm sure that we'll all get the update on what those new administration codes are for COVID vaccines. As it is right now, we've got more administration codes than we know what to do with. So I recommend that if you are administering COVID vaccines, that you are using the Appendix Q as your Bible in order to facilitate which vaccines are we using. Because besides the Pfizer and the Moderna vaccines, we also have the Johnson & Johnson vaccine, the Novavax vaccine, and the Sanofi Pasteur vaccines that were being used over in Europe have now been approved to be used here in the United States as well. So some other vaccines. I don't know how to pronounce that vaccine, the Kukuyanga. I'm butchering it, right? But whatever that is, I don't want it. So I'm glad there's a vaccine for it. There is another injection that has been developed for RSV. Now, this is not the one that we see on TV. This is another intramuscular RSV vaccine that has been approved. We have smallpox vaccine, monkeypox vaccine. You have your meningococcal vaccine. We always have those things kind of update for us as the viruses mutate. We find more vaccines to combat those mutated forms of the viruses. All right, our very first programming code, and I'm so super excited about this. The medicine section, again, things were allocated into the right sections because technically this is not a surgical procedure. This is after that cochlear implant has been implanted into the skull, that osteo-integrated sound processor has been already placed in there. We've got to go in and do programming and analysis and assist those patients in finding the good sounds and the pitches and the tones. And I'm not an audiologist, so I don't know what I'm talking about, but those things that we see, that how they're programmed. So we have a new code for that diagnostic analysis and programming for the first 60 minutes. and then an add-on code for each additional 15 minutes. Now look at how many parenthetical notes are there. I think that is fantastic. So it's really going to guide us to the right code, depending upon what we are analyzing today or evaluating today for this patient with their auditory osteo-integrated sound processor or cochlear implants, right? Here is another new code. I think this is fascinating. Again, I always ask the question, if we're able to break down calculi in the kidneys through lithotripsy, could we not find a way to break down calcium in the arteries? Well, the answer to that was yes. And it was a long time ago. It wasn't me that thought this up, and I can't take credit for it. Actually, we had a category 3 code because this is something that has been done, and it was actually promoted to a category 1. Now it's an add-on code, right? So when someone is having angioplasty, either a balloon angioplasty, or they're putting in a stent or a atherectomy, whether it's the native coronary artery or a bypass coronary artery, they have the ability to go in with a tool that emits that lithotripsy, those waves, to break down any additional plaque that might be remaining in that coronary artery. How cool is that, right? So not in lieu of the angioplasty, but in conjunction with the angioplasty, we're able to go in and do lithotripsy on that plaque that's building up there and help remove maybe some of that plaque that is calcified within the artery there. Who knows? Maybe we can see less bypass grafts if we're able to salvage some of those arteries. I don't know. It's wishful thinking on my part, right? The phrenic nerve stimulation system. Remember, we had all of those new codes that were added to the surgery section for this really unique type of pacemaker as such. It's not for the heart, right? It's for the phrenic nerve to help with respiration. And so we've got some new codes for the programming. So about 30 days after the system is implanted in the body, we have to turn it on, right? So we turn it on, we activate it. There's a code for that. There's a code for the programming of that phrenic nerve stimulator. Often that programming will happen during a sleep study. Because again, I told you a lot of times people have respiratory problems while they're sleeping, that horrible obstructive sleep apnea there. And so we need to know if during that sleep pattern, do we need to increase the stimulation system or decrease it, or what we need to do there, right? So we've got all these new codes to help us with that programming or the interiorization. Oh, I mess that up every time I say it. I don't know. Anyway, what would a year look like without guidance on cardiac catheterizations? So this is simply guidance that was added to the cardiac catheterization, more so because they made so many changes to the congenital heart defect. They actually separated heart catheterizations from the normal heart to the congenital heart. They've got their own set of codes there. And those congenital hearts conditions could be conditions like having a hole in your heart, or maybe there is a septum that didn't close properly that was supposed to when we were developing, right? So this is problems that we were born with, not problems that we acquired later on in life. And so we've got a separate set of codes for the heart catheterization for congenital heart defects there. Additional guidance when we're using a contrast injection during these procedures there, we want to make sure that we're using the proper codes, especially when we're seeing venography being performed during the heart catheterizations. And believe it or not, we got a whole new set of venography codes for those cardiac catheterizations for congenital heart defects. So remember, a couple of years ago, a year ago, maybe last year or year before, we got the new cardiac catheterization for congenital heart defects. And now we've got specific venography for that cardiac catheterization for congenital heart defects. So here are those new codes there. Venography for a congenital heart defect includes the catheter placement, radiological supervision, interpretation. And it is a parent code for, the first one is for the anomalous and persistent superior vena cava. We get into the zygos and the hemizygous venous system, the coronary sinus, the venous collaterals originating at or above the heart, and the venous collaterals originating below the heart. So venography is the new code set that was given to us. Intracardiac echocardiogram during a therapeutic or a diagnostic intervention did not change, my friends. However, look at the parenthetical guidance that was given to us. So we use this in conjunction with those specific procedures there, those catheterization procedures, those heart surgical procedures. A lot of category 3 codes have been added to this as well. Ooh. A revision to chemotherapy administered into the peritoneal cavity via, no longer an indwelling implanted, but just via a port or a cath. There is a new parenthetical guidance that tells us that for that intraoperative hypothermic intraperitoneal chemotherapy, or that HIPEC, we've got some new codes. So they've added some additional guidance because we've received these new codes. And this is for a treatment that has just absolutely exploded. The first time that I heard of the administration of chemotherapy into the intraperitoneal cavity there in the early 2000s, it was like novel, it was sci-fi. And now we're seeing this more and more common. So just to give you a comparison, in 2002, there was about 200 of these that were done. And now we're looking at them being done in the tens of thousands every year. So that's how much we have really expanded this type of debulking type of surgery there. So we've got some new codes here. The intraoperative hypothermic intraperitoneal chemotherapy procedure. It was a category 3. Now it is a category 1 code. It's for the first 60 minutes of that intraoperative chemotherapy procedure. And then you have a code for additional 30 minutes. And don't forget all this lovely parenthetical guidance here of when we may see this chemotherapy being administered, what other procedures would lead us to this chemotherapy administration. Just a little bit of an editorial change to specify the excimer laser treatment of psoriasis. So they're doing it by total skin area that has been treated there. And an excimer is a molecule that quickly forms when two different things come together, and one of them has a shell filled with electrons, like noble gases there. So we'll use this to break down or to remove that inflammatory skin that we are familiar with psoriasis. Very interesting. This is another one that I think is absolutely so incredibly cool. So this is the application of a modality of one or more areas of a low-level laser therapy for post-operative pain reduction. Now, they're giving us some parenthetical guidance there, but you also want to make sure that you're reaching out to your payers. Not all payers are on board for LLLT devices or reimbursement for it. Finally, we have some caregiver training without the patient present. Boy, let me tell you, it's very hard sometimes because we spend a lot of time teaching caregivers, especially those caregivers that are going to be taking care of patients as they leave a hospital setting or as they leave a nursing facility setting. And they're still going to have needs that our caregiver is going to be facilitating that patient with, activities of daily living that caregiver may need to know specifically. I'm having a surgery that's going to come up here in a few weeks. It's just a shoulder surgery. It's not anything fancy, like you don't get a brownie or a sticker for it or anything cool like that. But I've already started talking to my husband, like, you got to learn how to brush my hair. You got to learn how to use that curling iron. Oh my God, is he going to help me with my makeup? I hope not, right? Anyway, there's education now, and it doesn't require the patient to be present because oftentimes, schedules don't coordinate. How does the occupational therapist who's doing a lot of these trainings, how do they get paid for it? So we've got a separate set of codes that have been added for one-on-one training and another code that's been added for group training. So here's what that looks like. You've got caregiver training in strategies and technique to facilitate the patient's functional performance in the home or in the community, activities of daily living, face-to-face initial 30 minutes. There is an add-on code for each additional 15 minutes. And then there is a separate code for a group training of caregivers where we are providing that same group training. Now, remember, this is not like teaching caregivers or teaching people to be general caregivers. This is for a specific patient, right? We're not billing for education. We're billing to help that caregiver care for a specific patient that's going to be absorbing this CPT code. Now, Category 2 codes didn't get a new Category 2 code, not a one, but CPT did give us an entire list of resources. So who requested these Category 2 codes? What do we use Category 2 codes for? Is there any additional information about those Category 2s? HEDIS measures, MIPS measures, who is the one who is following these types of measures? All those questions that were never answered, here are your answers. You can easily access any one of these organizations to get more information on that specific Category 2 code. Category 3, we're not going to go over. We just don't have time to go over all the new codes. So I recommend that if you're working for a provider that's innovative and cutting edge, you may want to take an additional education just on Category 3 codes. But there were 82 new codes, 13 revised codes, 32 deleted codes, and a lot of those were promoted to Category 1 codes. Congratulations. The moment you've all been waiting for. E&M changes. Boy, have we had E&M changes over the past few years. And I got to tell you, I was thrilled that we had changes. I just wasn't thrilled with the timing of all those changes. We had something going on called COVID. Yeah, it took up a lot of our time, didn't it? And in the midst of this, they thought, well, let's just give them something to chew on for a while. And they gave us a bunch of changes. And we still are seeing some clarity from all of those changes. So the first one was a major one. I was so excited to see this. These are updates to the split and shared services. Again, if you have your CPT book with you, you can follow along page 6, or when you get a copy of this handout tomorrow, when you go to work, you can open up your book and take a look at this guidance as well. Now, the split and shared visits. The first part of the guidance tells us that this is when a physician and a non-physician practitioner, like a nurse practitioner, physician assistant, clinical nurse specialist, midwife, they are working as a team to provide service to a particular patient. Now, depending on the payer, Medicare only pays for split and shared services in a hospital setting. If you want to know if any other payer pays for split and shared services outside of a hospital setting or even in a hospital setting, you want to make sure you check with that particular payer. Remember this, AMA and CPT are simply the codes and the guidance for the codes. They don't guarantee payment by anybody. They're simply giving us the codes to translate the service that was performed, that clinical service that was performed. So for communication purposes, not a guarantee of payment. You've heard that a million times, I know, but I just want to remind you of that CPT is not a guarantee of payment. We still need to do our due diligence and check with our payers to see which one of those payers is going to pony up for these services, right? All right, so again, Medicare, split and shared service only in the hospital setting. Physician, nurse practitioner, physician goes in the morning, sees the patient, orders some tests, makes some notes, evaluates the patient. Nurse practitioner comes in later in the afternoon, reviews the results of those tests, makes some decisions, changes in the plan of care. We can only bill for one visit per day. So how do we do that? We combined those two visits together. And that combined information can be reported either on time, right? We total the time that was spent between the two visits, or a sum of the time, right? We add it together. It's not a range. It's not a start and stop. It's a sum of time, right? And whichever provider performed the substantive portion or more than half, that's the provider will bill for that joint visit on that day, right? So it could be the physician, it could be the nurse practitioner. The time that we're adding together is face-to-face time and non-face-to-face time in performing services for the patient, right? So think about it from that perspective. Time, the substantive portion of time, or the most amount of time, or more than half of the time. And then we can bill it under that provider's NPI number as if they had performed the entirety of the two summed visits together. And it's only on that date of service. Or we can also combine the two visits, and based on medical decision making, we can report the provider who performed at least two of the three elements based on MDM. So two of the three elements. Now, if you look at this, I'm going to be honest with you. There is a note that says when reporting medical services as part of a team, a significant part of the medical decision making involves the physician or other qualified healthcare professional creating or approving a plan for managing the patient's health issue. That is one sentence. The very next sentence says, by doing so, the physician or other qualified healthcare professional has performed, not supervised, not approved, has performed two of the three elements based on the selection of the level of E&M service. So if your physician is going to bill for that visit, your physician has performed the problem complexity to its entirety, or the data complexity to its entirety, or the risk complexity to its entirety, two of the three components in its entirety, and that provider can bill for that combined or shared visit. Now, CMS has also said we approve and follow and CMS's description of split and shared services. So the description of the service will be accepted by CMS. And I don't know about the other payers, right? You'd want to make sure you check with them as well. But remember, CMS says we accept it as long as it's in an inpatient setting. All right, I beat that one enough. Multiple evaluation and management services on the same day. So the following guidance is going to apply to E&M services in a hospital inpatient, observation, nursing facility. Now remember, only a patient can receive more than one E&M on a particular day, but it's going to depend on the settings. They can't be in this, it's going to be different settings there that we're going to see those. So let's kind of look at where those are. Now, per day, the hospital inpatient and observation care services and nursing facility services are reported per day, right? So they're saying that place of service per day. So when multiple visits occur over the course of a single calendar day in the same setting, a single service is reported. However, right, when we're using medical decision making to select a level of E&M service, we can use an aggregate of E&M that has happened over the course of the entire day. So remember, split and shared, you got two providers that are seeing the patient. This one is saying that one provider saw the patient in the morning. You can add that, all of that data to a visit that happened in the afternoon, and you can add all of that to a visit that happened in the evening. And when you combined all of that information together, you can report the highest level of evaluation and management that is supported with all of those components of evaluation and management, or you can combine the total time, the sum of the total time on that whole day together. So we talked about split and share, but we could also do that with one independent provider as well. Now, they also gave us guidance on a patient that might be treated in different facilities. So maybe you have a patient that is discharged from one hospital and admitted into another hospital. And it's the same doc. Imagine that. Doc is discharging them from a hospital in the north end of the state, and they're transferring them to a hospital closer to home in the south end of the state. and they happen to have privileges at both hospitals. So they're discharging them from one hospital, admitting them into another hospital. And that's okay, as long as it's a separate facility, right? A hospital to hospital transfer. And we're not combining the time. So we have a hospital discharge that is based on time, but the admission to the other facility cannot be based on time. So during the day, you can have one time base and one non-time base. I know, clear as mud, right? Oh, right. No time should be counted more than once. And this could also be if somebody is transferring from a hospital bed to a nursing facility bed. Let me rephrase that. Hospital beds are considered to be acute care services. And when a patient maybe has a hip replacement, a couple of days later, they don't necessarily require acute care anymore. They can go to a subacute care or to a rehab facility. And oftentimes, a hospital may have their acute section of the hospital, and they could have a rehab or subacute section of the hospital. It is a different level of care in that subacute or rehab section of the hospital. So because we're changing the designation from acute care to subacute care, that patient can again be discharged from the acute care and admitted into the subacute care, and we can report both of those services. Just remember, you can't report time for both of those services. So you'll have a discharge with time and admission to the acute care facility, the subacute care facility based on medical decision making. Emergency department. So you can have a patient who is seen in the emergency department by a provider, and then the provider admits the patient to the hospital. Now, if they do not bill the emergency department, then they can bill the admission, and they can count all of the service that happened in the emergency department. Now, remember, emergency department is not billed on time at all. It's only medical decision making. But if you're not going to report the time that you spent in the emergency department, and you're not reporting the E&M service in the emergency department because you've subsequently admitted them to the hospital, then you can count the medical decision making or the time from the emergency department to the admission. So if you forego reporting the actual code for the emergency department, you can count the time or the medical decision making in your admission into the hospital. Now, admission and discharge, we've kind of already talked about admission and discharge from one location to another location there. We can do it based on medical decision making or time. And it is the same whether we're discharging that patient from observation or if we're discharging them from inpatient care. Here's another scenario here. If a patient leaves the hospital and they come back the same day, this actually happened to a member of our family who was discharged in the elevator on their way down to get in the car and go home, and had a massive seizure in the elevator and had to be immediately readmitted to the hospital. Well, from a provider's perspective, we have to make sure that we're only billing for the same level of care. Now, this is acute care and acute care. We can either bill the discharge and a subsequent visit, or we can bill a subsequent visit and an admission to the facility again, one or the other, but not both. So there will be a subsequent visit and a discharge, or a subsequent visit and an emergency care. I don't make the rules. I'm just telling you what they said, right? All right, critical care services, in neonatal intensive care, pediatric and neonatal intensive care, they all have their critical care, they all have their own guidelines built into the section of CPT. So please make sure that if you are reporting those services, that you're going to that specific section for guidance on critical care, neonatal intensive care, and pediatric and neonatal critical care services. Transitioning from the office or other outpatient home residence or emergency department and a hospital inpatient observation and nursing facility. So for a patient that is seen in two different settings, only one service is reported. So if they're seen in the office and then seen in the emergency department, we would report the emergency department. If they were seen in the office and then seen in the nursing home, we're only going to report the nursing home. They've also given us a lot of guidance. They updated the table of risk for us, and they have updated the term risk. So the term risk, take a look at this right here, is used in the definition of this element, risk, to relate the risk from the condition. While the condition and the condition risk and management risk may often correlate, the risk from the condition is distinct from the risk of management. So the term risk, as it's used in the definition of this element, relates to risk from the condition. Another guidance that has been given to us in the E&M was parenteral controlled substances. So parenteral substances are administered, or parenteral means that it's administered via injection of some sort, right? Intramuscular, subcutaneous, intravenous, intradermal, local injection, all of those are parenteral, right? They're going through our skin and they're entering our body in certain places of our bodies, specific locations there. The next thing they're talking about are controlled substances, opiates, stimulants, depressants, hallucinogenics, anabolic steroids. Now, there was a myth that if you were administering a controlled substance parenterally via injection, that it was automatically a high risk. And CPT came back and said, no. Listen, there are a lot of people that, the providers may not think that administering this medication via injection of some sort is a high level risk. And so we need the providers to tell us, for this particular patient, this particular injection, is it high risk to the patient or is it not high risk to the patient? There's no automatic default. Now, 1995-97 guidelines, we had a default. There is no default in the 2023-2024 guidances that have been given to us. Now, in evaluation and management, they are also talking about time, and they're reminding us that there is no concept of obtaining the midpoint when it comes to evaluation and management. So there's no midpoint. There's no saying that you can bill a 20-minute service when 10 minutes has been performed. No, you cannot do that, right? So you must make sure that you have met or exceeded the time requirements for evaluation and management. And later, when I show you the changes in time, that's going to make a little more sense to you, right? Also, for prolonged services, CPT is now aligning with the explanation that Medicare has given to us, that a full 15 minutes of time must pass before we can report prolonged services 99417 or 99418. Oops, that went the wrong way. Also, the CPT also told us that the total time is defined by summing the time personally spent by the physician or other qualified healthcare professional in assessing and managing the patient. It could also include counseling and education, communicating results to the patient, family, caregivers on the date of the encounter. Remember that we cannot count our ancillary staff their time. This is only going to be the physician or the qualified healthcare professionals. And this is not talking about split or shared or anything like that. We're just talking about their personal time that was spent taking care of the patient today. We need a sum, not a range. We need a sum, not a start and stop time. We need a sum of all those time. Total time on the date of the encounter is a calendar date. So if we did start a particular visit based on time, say that they're in the hospital setting, and we started the encounter at 11 o'clock at night, and that encounter lasted till 2 in the morning, we're going to report the date of service, one single date of service for that total time on the time that the service was initiated. regardless of the fact that it went past midnight. If it's a continuous span of time that we're spending with that patient, it'll be on the date that it was initiated. Consultations that are performed in anticipation of or related to an admission. So a patient is seen in the office or in the emergency department and on a consultation basis, and then admitted into the hospital facility. That visit in the hospital facility will be reported as a subsequent care for that patient. Now, as we start to talk a little bit about time. So hospital admission and discharge service care, that is a admission and discharge on the same day that lasts for more than 8 hours, we report a single code, our 99234 through 99236. Again, hospital, inpatient, or observation, admitted and discharged on the same day, spending more than 8 hours, we report one of those 3 codes, depending upon what the medical decision making is or the total time. Inpatient hospital observation, admitted and discharged on the same day, but less than 8 hours has passed. We only report the initial encounter code. Inpatient hospital observation care and discharge on a different date of service. Well, on the date of admission, we'll report our 99221 through 99223, and on our discharge, we'll report our 99238 through 99239. And if they're there for more than 2 days, then that'll go over, we can add those subsequent visits on those interim days, right? There's a nice little graph that was added to CPT, and they are advising us that we don't report 99238 to 39 in conjunction with 99221 through 223 for admission and discharge services that are performed on the same day. Now, we'll remind you that if you're using codes 99234 through 99236, 2 notes are required. You have an admission note and a discharge note. 2 notes are required, 1 code is reported. Once again, we've got a couple of examples here from CPT. And when can we use our prolonged services? Our prolonged services can only be reported when we have exceeded or surpassed an additional 15 minutes beyond the total time of that particular encounter, the greatest amount of time per encounter. So for example, you can only report 1 unit of 99417 for a new patient when you've exceeded 75 minutes on the date of the encounter. Same thing with established patients. You cannot report a 99417 until you have surpassed 55 minutes of the 99215. And they made us a nice little table here so that we could see how we report these codes. When can we report a unit of prolonged service? And when can we report that second unit of prolonged service? So again, it's a sum of time, not a range, not a start and stop. It is a total sum of time. Now, last but certainly not least, we had a change to time on our evaluation and management office and other outpatient services. So for our new patients 99202 is no longer a range. They have revised the code to read, when using total time on the date of an encounter, the code selection, 15 minutes must be met or exceeded. For a 203, 30 minutes of total time must be met or exceeded. A 204, 45 minutes of time must be met or exceeded. And for the 205, 60 minutes must be met or exceeded. Why did they take out the range? I don't know. Nobody asked me. I have a theory, though. Talking to a provider, I was doing provider education. A provider came to me and said, Christine, I spent 32 minutes with this patient. Technically, I should have reported a 99203. I just didn't feel like it was a 99203, but the range of code says that it's 32 minutes. I have to bill a 99203. So my thought process is maybe that the range was removed to allow those providers the comfort of selecting a lower level of service that may be more appropriate when they have exceeded the total time. So that's my thought process there. For our established patients, the 99212 now requires that when using total time on the date of the encounter, the code selection is 10 minutes must be met or exceeded. The 213, 20 minutes must be met or exceeded. The 214, 30 minutes must be met or exceeded. And the 215, 40 minutes must be met or exceeded. Another change was for our nursing facility. So the 99306, actually, we lost here. We lost 5 minutes of time. In order to report the 99306, that when we're using total time on the date of the encounter, 50 minutes must be met or exceeded. So again, that initial nursing facility care, 50, not 45 minutes must be met or exceeded. Subsequent nursing care for the 99308, 20 minutes, not 15, must be met or exceeded. 20 minutes met or exceeded. The last new code for evaluation and management is for the pelvic examination. This is an add-on code. If you look at the parenthetical guidance tells us that we can add this to a new patient visit in the office or other outpatient setting, an established patient in the office and other outpatient setting, consultation in the office or other outpatient setting, or any of our preventive services for either a new or established patient there. Don't get all excited. There's not a whole lot of reimbursement that's attached to this. CPT actually published this code for us only with a practice expense allowance to the CPT code. That practice expense was to cover when we needed a chaperone to come in during that pelvic exam. So what CPT actually said was the consideration is 4 minutes of clinical staff time associated with chaperoning a pelvic exam. So if you have a male provider who's performing a pelvic exam, they require a staff member to be present during that pelvic exam. Now, do we have any more guidance? No. Did they say, does it have to be, what if it's a woman doctor? They didn't say. Did they say, what if there's 2 people in the room with the doctor? They didn't say. I would imagine that you would still only be able to report this once. And it is an add-on code. So stay tuned for more guidance, maybe from ACOG, on how do we report this pelvic examination add-on code. Whew. How about some questions? Stacy, did you have a chance to monitor the chat box while I was chatting away?
I did. Nobody's asked questions so far. So we do have one. For a telephone appointment visit, should we bill 99211 or 99458?
For telephone?
I'm assuming you're talking about telehealth with audio only. Is that accurate?
Telehealth with audio only would still be your 99441 through 99443 codes. Be very careful. Not all payers are paying those. I got a big old notice from Aetna that says, nope, not paying for those. Medicare will still pay for those through the end of the year, but Medicare is pretty clear that they have no intention of keeping those codes. So don't get married to them.
Was that your question, Erica? Okay. I have a question.
Sure.
Could you talk to us again? We have, I work for a health system, so we have multiple hospitals, multiple facilities. Can you talk again about the different facilities? So like if like our cardiologists are all considered one team, so we can only bill, everything they do in a day, they're considered one.
Mm-hmm.
If one of them from the same specialty discharges from one of our facilities and then admits to another one of our facilities in the same day because we need higher level of care or something, does that qualify?
So you're going from like a subacute to acute?
Well, they would be going from like one hospital, but they would need maybe a high risk PCI that the other facility isn't equipped to handle.
Yeah. Yeah. So absolutely, if you're going to a higher acuity of care, then you
Uh-huh.
could report a discharge and an admission. But remember, the admission has to be based on medical decision making because your discharges can only be done on time.
Okay.
Mhm.
And then Jamie asked any info on G2211.
I love G2211. I do now since we had some new guidance come out. What was it, Thursday or Friday? So G2 at 2211 was really designed for Medicare. Hopefully, all the Medicare Advantage plans will follow suit. It's not a guarantee that they absolutely have to, but so far, so good. I've heard nothing but good things. Doesn't belong to the commercial plans. Um, and it is for those patients that are the visit is establishing a longitudinal care with that patient. So they've already said that there's a few specialties that they probably won't see a lot of G2211, maybe dermatology or OBGYN, but they will see a lot with primary care. They said eventually up to 54% of all primary care visits will be reported with the G2211. That we'll see this maybe more with rheumatology when they're handling a lot of those chronic biologic conditions. We'll see this with endocrinology that are handling diabetes and hypothyroidism. And really, it is to encourage those providers to have those relationships with the patient. There's not a whole lot of documentation requirement for the G2211. I would imagine that documentation would be very similar to what we would expect to see. Please return to the office if you're not feeling better, or in 3 months, or if it gets worse, or right, that would be supporting that longitudinal care that the G2211 really is trying to promote. Is that is the big focus, is that longitudinal relationship. Hopefully to encourage patients to come to the doctor rather than the emergency department. That's my impression of it, but there has been some guidance that has been given to us. Yep. Primary care visits are going to be closer to about 90% of eligible visits. Now, remember, you can't report G2211 if you're reporting modifier 25. That they don't expect that this would be on for those conditions that you would not need to establish that longitudinal care. I don't know what that means because, again, I think of my mom, who is a very healthy woman who never goes to the doctor, no chronic conditions at 80 years old. I got good genes. And but I'd still think that her doctor wants her to go to her primary care if she does get something acute, if she sprains an ankle, if she gets an upper respiratory, that longitudinal care, she needs to go there, maybe not urgent care or to the hospital because they've got all her records. So anyway, I'll get off my soapbox about that, but let's see. We've got some good questions that are coming in now. We bought some time.
Yeah. So for Mindy, yes, we will be sending out the slides this week. Alonda said, so I work in a freestanding emergency room. Can we use 23 for place of service?
It depends, Alonda. There are emergency room departments that are not open 24 hours. That's a loaded question, but you can have my email address and you can send me an email and we can get to the bottom of this question together.
Awesome. Vicky, I'm not sure that I understand your question. Could you either come off mute and ask it? Vicky Jack.
While you're doing that, Kay asked, prolonged services with or without direct patient contact on the date of an E&M does not include start and stop times. We don't want start and stop times. CPT was really clear. They want a summation of time. Add all of your start and stop times together if you want to, but the overall needs to be one time. 62 minutes, 73 minutes. Give us a total summation of the time that was spent on that date of service, face-to-face and non-face-to-face, by the provider.
Hey, Victoria asked G0296, is there anything special about that code?
G0296, is that that's not the SDOH. That's one of the newer codes that was approved in the final rule. I can't remember that off the top of my head, but if you want to send me an email, I'll send you what I have on it.
Oh, Alonda said we are open 24 hours, but then she said, okay. Is Mary Fran said, is it still necessary to add modifier 25 to the E&M visit if the RN did a vaccination?
Well, usually the RN is really working incident two. There's an order from the physician to administer that vaccination. And so it would be reported by the physician, not the RN, because they can't get reimbursed for anything. And so you would have to, certain payers are going to require you to add a modifier 25 in order to get the E&M and the administration of the vaccine. And in that case, if you've got to add that modifier 25, G2211 is out the door.
Sorry, my thing just, there we go. Charities asked, there are 5 new codes for Pfizer and Moderna vaccines that were not published in time for 2024 CPT. Do you know if these should be used instead of all of the codes currently listed or not until it's in the book?
Charity, you should send me an email and I will send you the errata from CPT that will give you the actual dates on there so that you're not doing what Christine said, you're doing what the actual printed publication says.
See, scrolling. Does Medicare still want modifier 95 for telehealth?
So far, I've heard that if it is a code that is appropriate for modifier 95, then it should be. But don't forget that starting January 1, place of service changed. No longer going to be the place of service that you would have usually seen the patient. It's going to be place of service 02 if they're not at home, and place of service 10 if they are in their home.
John just asked, what is the latest G2211 guidance that was just released?
Oh, let me pull it up from my email. Like I was emailed to me about 6 times over the weekend. Did you see this? Yes, I saw this.
Was that the new MLN Matters that came out?
Yes, and can I drop it? No, it won't let me drop and drag. Okay, so let me open it and give me 2 seconds. Go ahead and ask a question because I can multitask.
I'm not seeing any more questions.
Oh, that's great. But if you think of a question later and you're like, gosh, I forgot to ask that when Christine was on, that is okay because you now have my email address. You can reach out to me and I will be happy to answer that for you, or get the answer for you even better, right? Meanwhile, catch us tomorrow at noon. I'm going to have Dr. CJ Wolf on the show.
Oh, we
are
love
going to be talking. I know he's so much fun. I just signed up for his coder med school, and it is amazing. Actually, this is the transmittal that I just put in the box. And let me see if I have the prettier version. Oh, here's the MedLearn Matters. I'll put that in the box next. That was the actual transmission, and this is the prettier one.
Awesome.
Oh, Lauren put it in there too. So thanks so much.
Yeah, CJ, I'll be listening. CJ presented last year for our chapter and then again at our seminar in the fall. And he's always so great too. He did an interactive one for the seminar where he gave clinical symptoms and things and had the participants try to down, and it was very, very interactive. It was a lot of fun.
That's
so
awesome.
I always love his stuff. But yeah, if anybody we've promoted him with the chapter too, but if anybody needs additional coding education, for sure, his coderbedschool.com is amazing. There are different levels there's free, and then there are different levels of membership that you can join, and he puts out videos because he is an MD, but he's been doing coding for a long time, so he can bridge that gap between the two.
Yep. Amazing. So I'm so honored to have him on the show tomorrow. And if you're not going to be able to make it tomorrow, that's okay. Like I said, we're on all the streaming platforms. YouTube, there's a QR code right there. You can scan it and subscribe, and it'll tell you every other week when we have a new episode that uploads. We're going to be covering CPT this season. So I'm looking forward to going through. Last season, we covered ICD-10. So if you don't love ICD-10, then
Yay.
maybe you want to watch the show. Could change your mind.
Yeah, I much prefer CPT to ICD-10 personally. Okay, thank you so much, Christine. This was amazing as always, so informative. For all of the participants, like I said, we will be automatically uploading your CEUs into the tracker if you are an AAPC member, or we'll be emailing you the certificate if you are a HEMA or an outside member. If you don't get either one, give us a couple of weeks. I'd like to try to get them in like within 5 and 7 days, but like we said, we had like 360 people at our peak here, and it is a manual process, so it's going to take some time to pull the report. And we had probably about 12 or 15 people having internet issues, and they had to bounce out and bounce back in. So I'm going to have to, figure out how much time was spent there and weed that out. So just give us some time. Plus, we have our new officers, so we'll be trying to train someone else besides me to do it. So we just need a little bit of extra time this month. And but if you don't have those within a few weeks, definitely let us know. Or if you need it immediately, let me know, and we'll try to get it in within the next few days. Thank you so much, Christine. We hope to maybe have you back again this year later with something else. Your risk adjustment one last time was amazing, and I'm so glad that we didn't have anyone bust in with inappropriate noise this time.
I've told that story before. I was like, you have no idea. Wow.
I made sure that I knew where my mute button was this time.
Mute all. Done.
Exactly. Question for Christine.
Yes.
When you have multiple E&M services on the same day, you cannot report an E&M based on time for each encounter?
Well, they're saying that for example, if you're going to the same level of care, so again, like the scenario I gave you, someone is being discharged from the hospital, discharge codes are only time-based codes. There's no E&M option for that. So if you are readmitted to the hospital on the same day, then that readmission cannot be based on time. Or if you're discharged from acute care to subacute care, then that admission could not be based on time because the discharge is based on time. Does that make sense?
Yes, got it.
They want to eliminate the possibility of time being bundled and maybe paid under 2 E&M services.
Thank you.
Sure.
I have a question, if you can hear me.
Yeah.
Okay. My name is Maggie, and I'm in West Virginia, and we've mentioned a couple of emails, but I had trouble logging in. So to the individual that's speaking about CEUs,
yes,
can you please provide the email that if I don't get them in whatever amount of time, I can email you?
Yes, it is. Let me just double check, because I don't want to give you the wrong one. For whatever reason, my brain always wants to switch it. It is STLAAPC social, so SOCIAL @gmail.com.
Thanks, Karen.
Okay, so it's and I've had eye surgery, had a vitrectomy, so I'm only seeing with one eye. So STLAAPC social @gmail.com.
Correct.
Okay, because I need them by the end of February, so I just wanted to make sure.
Yep.
Right. Thank you very much.
Oh, you're so welcome. All right. Well, thank you. Oh, didn't even realize my video wasn't on. Thank you so much, Christine. We really.
Oh, Corella is here. Corella,
And you said something earlier about our chapter size. We actually, it's funny, we have a lot of people that join from outside of the chapter for the virtual, but our chapter we're like 1,500 members strong here in St. Louis.
That's incredible. And you
Isn't
guys
it?
are so active, and I think that's amazing.
Yeah, we're very, very we're very happy with our membership here. So, all right. Again, if anyone wants to volunteer local chapter wise for our seminar to help planning, to help executing, or if you have any ideas for speakers or topics you'd like to see this year, please, please, please email us so that we can make sure to add your name and add your ideas.
Great job, Christine.
Thank you, John, and thank you for all of your tips. I really appreciate that.
All right. Thanks, everybody.
Good
Bye.
night. Take
Thank
care.
you.
Bye.
Thank you.
Bye.
Bye. Thank you.